Thank you. I'd like to thank you all for coming today, and thank you for the TVS for inviting me to talk. So the purpose of this presentation is to look at the prevalence of diabetes, understand the etiology of the diabetic foot and how this affects our treatment plans, have a quick look at biofilm and the implication for the diabetic foot ulcer, what antibiotic beads are, and I've got a case study to look at, and then I can discuss further reading with you if you should so wish. So there's so much to say about the topic of diabetes. So I've tried to focus it in bite-sized chunks that are easy for me to understand. So that means it'll be dead simple for all of you to understand. Diabetes is one of the most common diseases in the UK, and the prevalence is ever increasing. In 2013, there were 2.9 million people diagnosed with diabetes, and it was predicted that by 2025 there'll be more than 5 million. The life expectancy of people with diabetes is shortened by up to 15 years, with 75% dying of macrovascular complications. When I was researching this presentation, I looked at these figures, and I've seen them many times before, but I don't think I'd really absorbed them and understand actually how quite frightening it is. 10% of people with diabetes will have a diabetic foot ulcer at some point in their lives. Diabetes is the most common cause of non-traumatic limb amputation. 80% are preceded by foot ulcers. Mortality rates are high, 70% dying within 5 years of amputation and 50% dying within 5 years of diabetic foot ulceration. Then there's the financial implication of the cash-strapped NHS. For example, every £150 we spend in the NHS, £1 of that is on foot ulceration or amputation each year. So why do we have such problems with diabetic feet? If we have a look at the etiology, there's three main problems which can be broken down into further subgroups. There's neuropathy of the foot, so they have a loss of protective sensation, therefore they're open to trauma. They have motor neuropathy, so unfelt possible fractures leading to disformities, and autonomic, which is dry skin, which can cause fissures and callus. They also have peripheral vascular disease. Diabetics are twice as likely to have peripheral vascular disease as those without. Even in the absence of PVD, small vessel dysfunction contributes to poor healing. And then they also have an increased immune system deficiency. Increased blood sugars cause the immune cell to function ineffectively. And we all know that there's quite a few diabetics out there that are non-concordant and do run with high blood sugars. So the normal practice for at-risk foot, and this is a vast generalisation, is treatment of the underlying disease, so revascularising the foot if needed, tissue debridement, which is likely to be surgical if it's that serious, treatment of the inflammation and infection by doing a deep wound swab, x-rays, and antibiotics, disrupting the biofilm and offloading. Because I'm talking about an at-risk foot, the usual case of a course of oral antibiotics would not be effective in this situation. So antibiotics are a double-edged sword, really. They're seen as the miracle drug because they're life-saving and limb-saving, but they have many other downsides. Side effects can be quite drastic with people who already have many other comorbidities. There's the cost, there's the current resistance. Microbial populations are quite dynamic. Bacteria are constantly developing survival mechanisms, and antimicrobial resistance is one of the biggest threats that we have currently, which led on to antibiotic stewardship. So, what is a biofilm? This took me a while to get my head round, so like I say, I've broken it down into what I understand, so hopefully you will understand it as well. A biofilm is a community of bacteria that attach to a surface by excreting a sugary, sticky substance that encompasses the bacteria as a matrix. This sugary molecule is called extracellular polymeric substance. It is a strand-like structure which allows it to bind to the surface and to other cells, creating the matrix. It can consist of a bacteria or a number of different bacteria. The main thing to remember about a biofilm is that it takes 1,000 times the concentration of an antibiotic to eradicate bacteria in a biofilm than it does to kill them in the free planktonic state. So why is biofilm so relevant to diabetic foot ulceration? Because of the etiology of the foot, wounds go often undetected for a while. They're possibly not seen as bad as they are, and they've been treated in community by a course of antibiotics, or even possibly several courses. But due to a reduced immune response and microvessel disease, they're usually deemed ineffective. This means that the biofilm has time to develop. And remember, it takes 1,000 times the concentration of an antibiotic to kill a biofilm, which leads me on to calcium sulfate beads, or Stimulan, which is the product that we use, but there are many other products available. It's a solid phase on which to put high concentrates of antibiotics. They elute over time, releasing high concentrations of antibiotics at the biofilm. It is approved to be placed directly into the bone or the soft tissue, and there's a large list of guidance on the different antibiotics that can be used. Initially, it was used for bone infections, and a lot of the research that has been done is based from orthopedic surgery, and more recently, it's becoming used for diabetic foot ulceration. This is just a quick guide as to how you make up the beads. So you have a powdery solution, and you have a liquid if you're not using a liquid antibiotic. The instructions are all there for the different antibiotics that you can use and how to change the preparation if necessary. In the case study that I'm looking at, we use vancomycin. So we mix the powder with the vancomycin powder and then the dilute, mixed it into a paste, and then you have a mat that has several different sizes of beads that you would want to use depending on the size of the wound. So you have large beads, medium beads or small beads. And you paste the paste over this mat, leave it to dry for a period of time, and then pop them out, and you have then a selection of beads to put into your wound. This is just a study that there is that suggests that in vitro data suggests high levels of antibiotic are eluted over an extended period of 42 days, and that was in 2015. Most recent data has been, which is not published yet, would suggest that it can be, the antibiotic can be there for up to 90 days. So this is the case study that we first used the Stimulan beads on. It was a 45-year-old lady who was a smoker, poorly controlled type 2 diabetic, and she was awaiting bariatric surgery. And she presented to her GP like this. The GP then referred her to the surgical assessment unit, and she came to us and she had gas gangrene present. She seemed quite shocked when we discussed the fact that she was likely to need a toe amputation. She didn't understand the seriousness of the situation and was clearly very upset. We even had to discuss the fact that we didn't know how bad the underlying infection was, how deep it went into her foot, and we discussed as well the possibility that she may need a below amputation. So you can imagine she was very distressed. She went to theatre and she had a great toe amputated, and she had most of the infected tissue debrided, and she was put on IV antibiotics via a PICC line. So this is now in the October, so we're a good four months down the line. And you can see the wound is not looking too bad, macerated at the edges, but it's filled out, and she's been fairly lucky, I would say, to get to this stage. She had a 6-week course of antibiotics following IV antibiotics, following the surgery, and she had VAC therapy. I would like to say at this point that this lady was not particularly concordant with her treatment, despite her earlier shock that she needed to go to theatre and have her toe amputated, possibly her below knee amputated. She was back at work at this stage, and she wasn't using the footwear that podiatry had provided. She had a holiday home in Turkey where she would regularly go for 3 to 4 weeks and not have any healthcare input into her wound. So we would try and see her in the hospital on a 2 to 4 weekly basis, and she had had several episodes of further infection, and she'd required several courses of antibiotics in this time. However, she came back, this is now 11 months later, and there had been significant deterioration of the wound. She'd come back off holiday from Turkey at this point, and obviously the district nurses got in touch with us and were very concerned. It showed that there was osteomyelitis and septic arthritis of the midfoot with a deep collection at the plantar aspect of the foot arch, and it showed heavy growth of a Proteus, Microbis and Enterococcus fecalis. So again, at this point, we sat her down and we had to discuss the fact that she'd been very lucky the last time, but unfortunately she might not be as lucky this time, and that we would do all that we could to save the foot, but it was looking quite unlikely. So she went back to theatre and she had the wound debrided and she was put on IV antibiotics, a 4-week course. And at this point, our microbiologist had seen a presentation on the calcium sulfate beads, and because of the situation this lady was in, we thought we'd give it a try. So, like I say, we mixed the beads with 1 gram of vancomycin and we put them in fairly, I think we used the medium-sized beads, and she had no sensory function in her foot, so we were able to put them in quite deeply without any anaesthetic. Sometimes the surgical registrar did that. We do put them in theatre as well, but at this time it was we're going to do it as a last ditch attempt to save this lady's foot. So from October to November, she became a lot more happy with the treatment that we were giving her, possibly because she was seeing some improvement, possibly because it was the second time she'd had quite a scare in the thought that she was going to lose her leg. She was in an air cast boot at this time, and as you can see, there's a marked improvement in her wound. So following on, she was discharged home from the surgery with the stimulant beads in situ. They gradually dissolve over time, so there's no need for packing of different kinds of dressings. You just have the stimulant beads and then a covering over the top until they dissolve. She had a 4-week course of IV antibiotics and then went on to have a 4-week oral antibiotic course. And by the November, we'd healed her completely. So not only is there the implications for the patient, and I'm not suggesting that this is the be-all and end-all in at-risk feet. I'm just trying to use this and make you aware of having another tool in our toolkit when we're faced with a foot that looks like that. There's also the implications of antimicrobial stewardship, that local antimicrobials as opposed to systemic, less antimicrobial monitoring, so we wouldn't need to do the blood levels, less use of systemic antibiotics, so relieving pressure on a patient's admission, looking at length of stays, cost, etc., and also the outpatient antibiotic treatment. There's also less opportunity for development of antimicrobial resistance. I haven't gone into all the different case studies and research that's been done, but I have got a leaflet here with all of the articles in, should you want to see them later and discuss it with me. Those are my references. Any questions?
Thank you, Kate. That's excellent time management on the speaker situation. Are there any questions from the audience?
I can't see one.
Just to ask, why is there less risk of antimicrobial resistance, say?
Because you're not giving it systemically, you're giving it to the actual area of the foot. Right. So our microbiologist feels as though because it's just going to that one area, you're not getting it systemically, so you're not building up a resistance.
Okay, thank you.
Hi. In terms of the local resistance, it's interesting because there is a bit of disparity within the literature, because Valedroud-Jones says never give local antibiotics because it improves resistance, and it's just interesting to see what the microbiologists like to argue between themselves. My question to you is, though, is one thing that I've noticed since the vascular nurse has got really involved with the diabetic foot service is if that was a non-diabetic wound, wouldn't you want to just put compression on it?
Yes.
So do we need to embrace compression therapy more in the management of diabetic feet?
I would say yes, but I think there's, as we've discussed many times, there's such a fear out there of putting compression on patients, and especially with diabetics, knowing that they've got the microvessel disease. You know, there is this fear, whereas I would have been probably tempted to do it. And I think that's always going to be the problem, is my answer. I know. Yes.
Hi there. I just wanted to ask, was this patient in your case study, what was their peripheral vascular situation?
We did I think we did an MRA scan on her because of the state she came in on, and there was no arterial insufficiency there at all.
Yeah, it was quite surprising because she's a smoker as well, isn't she? So I just wanted to ask, really. Yeah, great, thank you.
Right, thank you, Kate. I know Kate works as an effective MDT team, and I think that's to be congratulated too, as MDT working has been a major factor this morning. Yes, thank you.